In this vlog we'll be comparing skills and capacities within the weight room. Firstly, it's important to understand the differences between the two. A skill is generally a motor control issue that can be improved through training and practice, whereas a capacity is a limitation which could be due to flexibility, anatomy or previous injury history. We're looking at both the squat and the RDL within this vlog. The first video is going to demonstrate an athlete with a capacity issue within the barbell back squat. As we pause the video on the final rep, we will be able to identify some of the issues that are present. Firstly, the athlete's hips are not level and she's slightly veering to one side. Secondly, the trunk is leaning forward. But I think the main reason that this may be present is because the lack of ankle dorsiflexion available to the athlete. If we unload the squat and make it a bodyweight squat, we can still see that some of these issues are present. She's not achieving parallel, she's still leaning forward within the squat, and there is still a reduction in range of dorsiflexion. As we have unloaded it, this will help alleviate any skill issues that may be present. The overhead squat further exacerbates this. As we can see, the heel is starting to raise off the floor due to the lack of capacity. The forward trunk lean has become even more pronounced, and the athlete is actually looking down as opposed to forwards. If we change the centre of mass by making this a goblet squat, it does in fact improve the situation. Firstly, the heel stays in contact with the ground and the amount of ankle dorsiflexion increases, but this may also be due to the trainers that she's wearing. Secondly, she's achieving near parallel with her squat, and thirdly, her head is in a much better position and therefore looking forwards. The athlete is demonstrating a lack of dorsiflexion capacity at the talocrural joint via the knee to wall test here. The knee to wall test has been validated by both Hall and Doherty and Kona et al. Some interventions that may improve the lack of ankle dorsiflexion include passive physiological movements via manual therapy and both banded and weighted dorsiflexion onto a step. Another potential intervention is to artificially increase the amount of dorsiflexion available by inserting plates underneath the heels. What this does is increase the range of movement available at the hip, knee and ankle. As a result, this allows the athlete to maintain a more neutral and upright spine and therefore keep the head in a more upright position. It also allows them to achieve near parallel within the squat pattern. Elevating the heels within the goblet squat not only has the benefit of improving the range of movement available at both the knee, hip and ankle, it also allows the athlete to evenly distribute their weight between their feet. The graphics on screen demonstrate this, and this is something that was picked up within the barbell back squat when there was no elevation of the heels. This final video demonstrates the athlete completing the barbell back squat with their heels raised. As we pause the squat at the bottom, we can see that the hips are level and that weight is evenly distributed between both legs. As we run the video on, we can see that the athlete maintains this position throughout the movement. The ability to maintain a near neutral spine while completing the exercise demonstrates that this really is a capacity issue and not a skill-based issue for this athlete. The second athlete will demonstrate a skill-based issue within the barbell back squat. Firstly, the athlete demonstrates an element of valgus during the descent portion of the squat. Secondly, there is increased external rotation of the right foot in comparison to the left. This is because the athlete demonstrates a lack of motor control within the squat pattern movement and therefore is compensating by improving the amount of range that is available. The athlete is also demonstrating lack of motor control via poor technique. This is due to the increase in lumbar extension when completing the back squat. By moving the athlete's centre of mass forward and into a goblet squat, it does in fact improve the lumbar lordosis that was present within the back squat. What does not change is the external rotation of the right foot. It also doesn't allow the athlete to achieve parallel within the squat. The overhead squat further exacerbates some issues. The right foot is still externally rotated. However, the lumbar lordosis that had been resolved via the goblet squat has now returned. Also, the athlete is now unable to achieve the depth that they had achieved within the goblet squat. Knee valgus is still present within a bodyweight squat, thus demonstrating that this is both a motor control and skill-based issue. Adding a mini band around the knee as an external cue may help this athlete to rectify this issue. The second movement that we're going to look at is the RDL. And we're going to look at this from a capacity-based issue. As we can see, the athlete is not rounding the back and is maintaining that relative neutral spine. However, the bar is only ever going to about knee level due to the lack of capacity and stretch within the hamstrings. They are also able to maintain the correct knee position and knee joint angle throughout the movement, further highlighting that this is a capacity issue at the hamstrings. The sit and reach test can be used to measure hamstring flexibility. This has been validated by Ayala et al. As we can see here, the athlete has a poor score within the sit and reach test, therefore concluding that they do have a capacity-based issue at the hamstrings. As per Davis et al., a passive 90-90 stretch and a passive straight leg raise can further be used to quantify the amount of flexibility and range available to the hamstrings. These can be seen in the supplementary videos on screen now. An intervention to try and improve the flexibility and thus capacity of the hamstrings is via eccentric exercises. Both knee and hip dominant hamstring exercises will improve both vertical length and strength and therefore rectify the capacity issue this athlete has. Soft tissue massage and manual therapy in conjunction with a hamstring specific mobility program is another option to increase the amount of capacity available at the hamstrings. Next, we're going to look at the RDL from a motor control and skill-based issue. Firstly, this is a video of the athlete picking the bar up to complete the reps, and already she has a flexed spine. As we move forward to see her complete the reps, we can see that this flexed spine remains throughout and therefore is classed as suboptimal. Not only that, the head is not in line with the rest of the spine and is in an extended position. Lumbar spine flexion is present throughout the set, and although this is suboptimal, there is no relationship between lumbar spine flexion during lifting and in the increase in lower back pain as per Saraceni et al. Adding a constraint to the athlete further emphasises that this is a skill and motor control based issue. The athlete is still presenting with a flexed lumbar spine and if anything is increasing the range of movement at the knee as they are unfamiliar with this movement pattern. Furthermore, the added constraint actually compromises the athlete's weight distribution, and this can be seen via the graphic on screen. By removing the constraint and moving the centre of mass forward, although lighter than the barbell, the athlete can now be seen to be demonstrating a deadlift pattern as opposed to a Romanian deadlift pattern. The positive within this is that the athlete is now able to maintain a neutral spine, which is something that we were unable to achieve previously. Now that the athlete can maintain a relative neutral lumbar spine and can complete a hinge movement pattern, albeit within a deadlift exercise, we can look to take this forward into the original RDL exercise. A dowel, and by constraining the athlete in a different way, we are able to complete the RDL and therefore hinge pattern, but this time with minimal knee flexion. We can see that this is still a skill and motor control based issue for the athlete, as they are unable to maintain the dowel in the centre of the back as per the right hand at the top, slightly veering to one side. This athlete was able to perform a hinge pattern with cueing, therefore demonstrating that this is a skill-based and not capacity-based issue. It is important to understand that both skill and capacity-based issues are both normally present within certain movement patterns. One normally presents itself as being the primary issue, but in fact by providing intervention to this primary issue, we can in fact improve both the skill and capacity-based issues.